I'm Ron Carlson with Health Jump, and today we're here with Sam Wilson, the Chief Technology Officer of Bainbridge Health. Thank you for being here, Sam.
Thanks for having me.
So this is the discussion in which we're just focusing on what would you say you do at Bainbridge Health. Tell us a little bit about that.
Great. So we work with hospital pharmacies to aggregate infusion pump data and look at medication administration from the sharp end of the syringe, so to speak. So we work with the infusion pump vendors to collect data from the infusion pumps, aggregate that, and then go back to the hospital, advise them on how to optimize their decision support to reduce alert fatigue, to better comply with Joint Commission standards, and then as well to look at it from a supply chain perspective, how to reduce cost, how to reduce waste, and that can have a big impact on numerous aspects of the pharmacy operations, not least of which is addressing diversion, addressing financial waste, or lack of human resources to efficiently produce meds, source meds, things of that nature.
Yeah, those infusion pumps. Having been from Minnesota, where all of the med device manufacturers are located,
it's true. Yeah.
Had the opportunity to been in a lot of local tech conferences where it was my first exposure years ago to this whole world of I had no idea how much the infusion pumps were in the Stone Age and how and now they're pushing them forward to get it so you have telemetry that you can pull off of it with a device or anything along those lines. So
absolutely,
what have you found in the world of infusion pumps? Has anything gotten any better?
A lot has gotten better. So obviously with the advent of the smart infusion pumps, where you're actually tracking the data, you're able to aggregate the data, to where I think the big focus for most of the vendors, the manufacturers, is with the integration to the EHR, and really trying to get to that sort of real-time integration where you've got either auto-programming so the EHR can send the order information to the pump, or the auto documentation so that the pump is sending the documentation back to the EMR in the EHR to keep those records and to facilitate that piece of it. So now you've got these comprehensive platforms where that you can have a monitor at the nursing station to say which patients are coming up to the end of an infusion, who needs a bag change, does somebody have an occlusion, so maybe a nurse needs to go back and check the lines in one central location. So they've really been focused on that. I think where a big pain point remains is so now you've got all this data, and what are you going to do with it? From a governance standpoint, how do you align decision support? How do you really dig into this, in all the various and sundry ways that a hospital pharmacy might want to investigate that data?
So is this just patients is it like in-home care as well as in the hospital? Or, what kind of, when you're dealing with these are the pharmacies in a hospital, right?
Correct, yeah. So we're focused on the acute care hospital space,
right on.
As opposed to, say, home infusions or infusion therapy centers. We do some work, some hospitals will have a chemo IV room, and we do some work with them looking at sort of timing of medications. A nurse might write down in a logbook what time, or in an EHR what time, but with the infusion pump, the exact time, the two different meds. And with the chemo drugs, 15 minutes off by 1 minute can actually have a pretty serious impact on quality of experience or even outcomes for those patients. There isn't quite as much availability of smart pumps in the home care setting. That's changing with better connectivity, more affordable connectivity, but that's been an issue. So we haven't really focused on that space quite as much, but we certainly are focused on the acute care hospital space.
I know there's a lot that they're still trying to figure out. The at home, is a phone a gateway? How do we securely manage patient health? It's so I think that's interesting that you're focusing on where they have that controlled network, where they've kind of got things figured out, right? That
they'd like to.
They'd like to.
They'd like to, and yes.
So what is it that is the pain that Bainbridge keeps finding that you're addressing over and over again? Smart, or what people say, a dumb pump? None of them are dumb, right? But,
No.
Where is that issue that keeps burbling up that you guys are uniquely addressing?
Yeah, so really what it comes down to is enabling the hospital to have their clinicians operate at the height of their license, as opposed to them being data clerks. And we'd all like to think that the hospital has an IT department, they've got an informatics team, that they can solve these problems. Well, there's 6,000 hospitals in the United States. Why should they all try and solve that problem 6,000 different times? When you've got an organization like Bainbridge Health that has deep clinical knowledge of what's going on from a pharmacy standpoint, from a clinical operations standpoint, from a supply chain standpoint, we can bring all that together and really enable the hospital to let their clinicians do what they do best. So get them out of Excel, get them out of Tableau. We can build, whether it's a calculator or a data discovery tool or our professional services over the top, where we go and do the legwork to research and do the documented evidence, sort of cross-referencing everything that they need in order to make an informed decision for their hospital. And so, we want to make a safety change. Well, what's going to be the financial impact of that safety change? Or we want to make a financial change. We want to reduce the waste for a particular medication. We're going to do that. We're going to switch concentrations. We're going to switch suppliers. How do we make sure our decision support is well aligned with that, and that we've got an education campaign for the nursing staff so that they can take that transition? Because none of these decisions happen in isolation.
I'm hearing the address the weakest link approach, right? It's not always just the plan. There's also the implementation, the training, and then I'd imagine there's some sort of follow through where you creating accountability? Yeah,
absolutely. So a big part of what we do, obviously our customers are very interested in making sure that the money they spend on us is money well spent. So we review every decision that we make with a customer over time longitudinally to make sure that the change that we wanted to have happen did happen. So we're tightly integrated with their CQI practices, and we're going to make this change. We're expecting this outcome. We come back 6 months later because we've got our data platform.
This sounds like a scientific method where you make a hypothesis and then you actually put it in and do observation and then analysis.
Absolutely. And because in a lot of cases, funny things can happen. We'll go to a hospital and we'll say, hey, you should change this concentration to reduce the waste of this very expensive medication by 50%. We think it's going to save you $500,000.
Awesome.
And we say that to that particular set of clinicians. They go ahead and make the change. But then if they don't communicate to their buyers, they're still buying that medication and they're just building inventory.
Oh, right.
And so
are you tied into that? Are you saying, now remember, like a good, like someone who does logistics or event management, that they're a specialist, they're going to go, and here's your checklist, don't forget this. People often forget a pair of extra shoes. And are you providing that whole
we do try to be very comprehensive with our customers. Try to ask those kinds of questions. We are very interested in expanding into all of these other pools of data that are in the hospital. A lot of the conversation I think in healthcare IT is around the EHR, is around the idea that there's this central repository of the clinical care information. At the end of the day, there's actually vast mountains of data that never make it into the EHR and likely aren't going to make it into the EHR.
Where are they? Where is this data siloed?
They're in supply chain systems. We've talked to some very large IDNs that manage that inventory in Marble notebooks.
Shut the front door.
I can't make that up. It's a real thing. A very large IDN. That's how they manage some of their inventory. So that inventory, it might be in IV management systems, in the medication workflow management tools. It could be in the automated dispensing cabinets. It could be in their carousel systems. A lot of times those systems are in some ways tied back to the EHR, but similar to the infusion pump, a lot of the source data never actually makes it in.
How are you pulling these disparate pieces together? So what makes Bainbridge uniquely suited to solve this problem? Is there something that you do that differentiates your ability to address this versus
so
any other alternative?
I sort of jokingly like to say it's that we have a high threshold for pain. But basically, we integrate with all of those systems. So we pull the data from those different systems and bring it all together in our own clinical data warehouse. That's very similar to data warehouse that the hospital might have, but is very focused on medication administration and the medication supply chain side, as opposed to, tracking patients, managing billing, managing, patient transfers and things of that nature, which the EHR is really good at that piece of the puzzle. These other operational systems, you could ask the question, why aren't you querying the EHR for the data that you're finding in Workday? And it's a very similar problem. There are these other operational areas within the hospital that aren't fully integrated. Some hospitals have tremendous data warehouse platforms where they've brought all this data together, but even in that case, that data is really managed and owned by a group of people that are experts in data. They're not experts in the specific clinical use case, and so we really free that data up and bring it right to the specific clinical use case.
This is where I hear a lot of data informaticists, where I'm like, all right, COVID hit, what changed? What growing pains just got amplified? And they just said, we just have more work. There's no downtime. And so they've always got a backlog of just, some of it's just like shift reports and all of the stuff, right? And to your point, I think this is why I hear some people call data lakes data swamps, is that just things get stagnant, unused, like no one's got the time when you're in charge of everything. You're really in charge of specializing in nothing. Right? And so you just have all of this information. So what I'm hearing is you'll leverage these existing data lakes, go out and where to shine the light and bring that information together.
If you've got a really sort of, there's always a new buzzword, right?
Bring it on.
And this isn't exactly a new buzzword, but if you're just getting into data lakes, well, go one step further Some people.
Sorry,
I've heard the data lakehouse is a thing, and I recently moved into my data lakehouse. But no, the data mesh, the idea of a data mesh, I think is really starting to gain some traction. And part of the idea is, you're going to have these different systems that are going to produce this data, and then you're going to have these various domain-specific applications that need to consume that data. Rather than trying to dump everything into one massive cesspool of unmanaged data, right? Or centrally managed data with a group of people and resources that are very finite and can't expand. Take a services approach and really try to build a platform where you can begin to compose these different aspects of the system together. And so I view us as really a part of that data mesh.
Okay, so the mesh though is it's not bringing all the data, but just the reference point. So indexing to the different sources of how to access it, or?
I think it's more of a mindset for how you're going to manage data within an enterprise. So we're not a data mesh provider. So
this is a philosophy. So it's more of a management philosophy of data.
Right. I think you're going to find there are products out there that really try to productize the concept of a data mesh. But I think if you use it more as a strategic sort of mental model for how you might think about data within your enterprise, whether it's a hospital, large manufacturing, or retail organization, or university, whatever it is, you're going to have lots of different data sources. You want to bring all of that together. The idea with the data lake is to centralize it and have one central tool or group of folks. In this case, it's really have good governance, have good standards, and then really try to make that data accessible to the different domain experts that can then put it together.
And those domain experts aren't ours in-house.
No, and that's where Bainbridge Health comes in. We're those domain experts. So if you've got this data mesh sort of strategy in place,
or the desire to create one.
Then or if you want to sort of understand where an organization like ours kind of fits in, it's really from there. We have some of our customers that take our data and they bring it in to their data lake, because we transform sort of that raw data into something that's more clinically relevant for the institution. Now we're experts in interpreting that. And so we can provide the professional services over the top, whether it's clinical or analytical, to really improve that. But we can also take sort of our sort of secondary data and bring that in to enable whatever other analyses they may want to perform.
So is the secondary data you're bringing in, is it enriching existing data sets, or is it just providing a tool for prioritizing or
in a lot of cases, so there's some enrichment. We don't generally bring our enriched data back in for various reasons. But
I can think of about 100. But
yeah,
continue.
but sort of, I guess the way I would look at it is, one way to think about the raw data that we consume is it's sort of like web click data, right? So, or clickstream data, and you could take that clickstream data and you could load it directly into your data lake, and then over the top of that, you can build various analyses on top of that to try to understand, extract individuals, whether it's a clinician or a stand-in for a patient. Most of the data we have is not identifiable, and we don't re-identify the data. What we really try to look for is sort of one anonymous sort of like series of activities that might represent a clinician's interaction with a patient, to then derive some further statistics on that to say, well, what is your override rate? What's your alert salience rate? You know, some of these higher level statistics. What's the resultant action? So a clinician gets a decision support alert. What did they do with that, right? So I'm told, hey, that's too high. Did I override that? Or better yet, did I cancel, try and reprogram the same thing, get the same error? Did I do that 4 times in a row and then ultimately override? Or did I just switch to a different drug that wasn't going to alert and now try to do that, really messing up the data stream?
Oh,
so,
I'd imagine. So it's someone troubleshooting,
right?
You know, like, it's every time you've tried to program something, you realize that you'd actually saved the same
right.
thing 4 times.
If you've ever been in a hospital, sat next to a patient bed while 2 nurses are struggling to get an infusion pump to do what they want it to do, they get really creative at a certain point because they've got a patient there that needs the medicine. And they're not going to let the infusion pump get in the way of that. So we can start to look at the data and try and identify those situations. And sometimes the solution is, hey, let's make that decision support better. Let's make the training around that decision support better. Or, you know, let's maybe address an individual practice problem that needs to be addressed.
Sure. So are you ever identifying issues that are hardware related that is valuable for the manufacturers? I know that might be a loaded question.
It's not a loaded question. I just have to think about how I can answer that question. So the device manufacturers have to go through FDA approval, and sometimes they need information from outside their own sort of device use, where they may need to understand how infusions are used generally. And so we can provide them with assistance there. We are providing some device manufacturers with what I call sort of our platform services, where, you know, hey, we're experts in this. We understand this data, and we can manage it maybe better than they can. Or maybe we can manage it, maybe not better than they can, but maybe in a way that's maybe a little more flexible from like a product resource perspective. Do they want to spend their time, you know, with their product people on sort of this aspect of it? Or do they want to spend their time focusing on, you know, really making sure that the connection with the EHR is exactly what it needs to be?
I see a lot of parallels between like Industry 4.0 and the smart factory, where initially a lot of the sensing and tracking at first was, oh, so we can now hold our vendors to, like, we can prove that this anomaly is occurring.
Right.
An unintended, not consequence, but benefit was what they first thought was going to be, now we can prove it, and they're going to, you know, like, prove the problem. The manufacturers, even one step further removed, would say, could we work with your factory and actually get that data? Because we could make an actual improvement on the next rev.
Absolutely.
And so it was really cool to see that one level of abstraction where the manufacturers themselves were not part of that initial conversation about accountability.
Exactly.
When they could then start seeing, because when you think about a manufacturer who typically sells through distribution, they're having a customer contact. So manufacturers oftentimes are just, I hope everything's going right. But they lose some of the context. So
correct.
I don't know. I'm seeing healthcare really following a lot of these trends that are like maybe 5-6 years trailing behind other industries that have kind of proven out the model
yeah.
and built enough tolerance for risk around security, wireless, encryption,
right.
and
yeah, and I mean, in some ways, it might be a question around sort of the hospital sort of having a better appetite for risk, but it might also just be that those technologies have matured to the point
totally.
where now they can meet the risk profile that the hospital has. And that's certainly, I think, in the context of COVID, been something that a lot of the conversations really focused around sort of health, the obvious pain points of the pandemic, right? There's sick people, different acuity for the patients that are coming in, it's impacting our supply chain, all of those conversations. Going on at the same time, there's a cyber war going on out there that we don't talk about a lot, but especially around vaccine development and collecting some of this patient information. A number of our hospital partners were certainly a part of, I think, that effort, and themselves became much greater targets than they ever were in the past. I mean, they're already big targets, but this certainly raised their risk profile.
Yeah.
I think I think every hospital CIO, CTO, or security risk manager has the same nightmare of getting a call in the morning while they're enjoying their coffee. I'm gonna do patient in this room because I can control the infusion pump remotely. Everybody's terrified about that.
Yeah.
So security is absolutely at the forefront of everybody's mind.
Yep.
And securing this data is absolutely at the forefront of everybody's mind. The data and using the data to understand the risks, whether it's device failures, whether it's better managing of the medication, being able to use that data to drive those decisions is fundamentally important. So you can't throw the baby out with the bathwater, so to speak. You've got to have the data in order to drive the decision making.
Yeah.
And I think one of the nice things about how we've really tried to build and model our platform is to really acknowledge what we do and what we don't need. We don't need all necessarily patient information. We don't necessarily need some of these other things. We can really try to manage that risk and really work with the hospital to how do we implement this in such a way that we're respecting and managing risk for you, but still empowering you to make decisions with that data.
And that's where I think there's an interesting conversation that we've been having at Health Jump, is the idea of health metadata. Right. There's a complete patient record that's identifiable and then it's de-identified.
Right.
But what if the data that you're pulling never knew who the person was? It just happens to be a series of factors that could be attributed to a random number, but it's never associated with the person, but it is a contiguous history of this med device with these health readings, and we also know these medications, right? And maybe we even knew the outcome of the patient, but we never knew, it was never associated. So these are little breadcrumbs that never could be re-identified. It's not the redacted document that's got the Sharpie that's marked things out and you kind of hold it up to the light.
Right.
I think it's a conversation that I'm interested in having in healthcare is what can we do with these valuable, right? We don't need all 10,000 records or fields.
Yeah.
We don't even need all 300 unless we're doing something fairly comprehensive.
Right.
Sometimes it's just 3.
Right.
Or whatever it is that the hypothesis would need to support the actual conclusions. So I'm fascinated in how we can see that risk profile, whether that's going to also be adapting over time, because data is crucial in making decisions, and everyone's so worried about the liability.
Right.
They're worrying about getting that phone call about, oh my gosh, this. So I think some of the risk management does come down to making recommendations of, well, how about we change how we're getting the data?
I think there's if you think about sort of the interoperability standards we have today, right?
Patient name, practice, then
You're really trying to address, I think, sort of the very rough, direct care for an individual patient, where you actually need all of that information.
Because it's the data supports the care for you or me or a loved one or my patient.
Right.
And
I think there's there needs to be maybe a new generation of interoperability standards that really try to look at and address some of these considerations.
Yeah.
And when you think about sort of dealing with aggregate data, the kind of data that we deal with, I think there's a whole fascinating area. If you look at the way, for example, Apple deals with credit cards,
yep.
Apply that same thing maybe to prescriptions where you can have intermediaries that never know. So sure, on the transactional side, I think there's a whole series of technological improvements that could be made there. But then when you come back and you think about, okay, now I've got this massive amount of data and I want to do population studies, or I want to do sort of machine learning, or I want to do larger sort of governance types of analysis.
Yes.
I think we really need to start to ask questions around federation and federation of data, so that the data can remain where it needs to remain, but maybe the analysis and their aggregates can come out. And it's certainly very complicated, and I think that sort of maybe the naive or the trivial approach is to just try to push up some of those aggregates and assume that because I've got an aggregate, it's not identifiable.
Did you know that Caesar Milan, the dog whisperer, already solved this one?
No.
So data at
Don't
rest.
tell me I'm barking up the wrong tree.
Oh,
Sorry.
Wow. Okay, first dad joke. All right, that's great. So follow me here, right? You've got your troubled dog that needs to learn some new behaviors.
Right.
It's a machine learning model that needs to be exposed to a bunch of real live data.
Absolutely.
Right? That dog gets walked to the sidewalk. Caesar comes out and takes it and leaves the owner on the sidewalk and takes it into his big fenced compound with like 80 other trained dogs that they've all been rehabilitated.
Right, yeah.
But they're a healthy pack that has all of the skills, all the things they need. 6 weeks later, they do the reveal. Caesar walks that dog back out after having been trained by not just him, but the pack.
Right.
And goes, here's your dog that is now a new and improved dog that had the benefit of all of these other dogs, but you're not bringing these home.
Right.
In fact, you have no idea who these were, but you have all of the outcomes that you were choosing to have, without ever, letting them out of that dogs at rest, although that never happens. My dogs are either they're at rest in emotions, just like data. So
exactly.
I never thought about that. I need some data names for some dogs.
There we go.
So that same idea though, if you've got models that need to be brought into data aggregate to be informed and learned, I really believe there are safe, completely secure ways, and it's like. And I think that's the challenge, is how do we have the conversation with people who don't understand data in motion, data at rest, how machine learning models are informed, what moves, what actually comes out, like how do these things, so I think that it's that whole, like, how many years needs to go by, how many use cases do we need to see for that comfort level? Yeah,
I think, a lot of the technology still has to be validated. I think, we talk about federated learning and things like that. I think there are still some questions from an adversarial standpoint. Hey, new concept. Okay, what are all the ways that might be exploited?
Yeah.
So I think some of that still needs to kind of go through the proverbial ringer for folks to feel comfortable with it.
Yeah.
So similar to some of these other technologies where it may have started out in manufacturing, and it's maybe not a question of hospitals developing more of an appetite for risk, but maybe those technologies sort of getting through the de-risking to get them to a state where they make sense in the hospital environment. But I think there are also sort of industry activities, right? You think about something like the fire standard, right? Very much about point to point. Now, there are efforts in there to try and get aggregate data through fire, and some of those efforts. What we really need is strong incentives or compulsion for vendors to participate in those standards in a holistic fashion. Yeah. It's one thing to say, well, there's an HL7 standard for this. It's another thing to say, okay, do you do anything other than ADT records?
Yeah.
Right?
Yep.
Do you actually support anything other than ADT records? You can have conversations with folks all day long about when patients show up and when they leave the hospital. But if you want to know whether or not the drug they were given was approved by a pharmacist, how well supported is that, and how standardized is that across all of the well-deployed platforms that are out there?
Well, I think that's actually a whole nother conversation that I'd love to have at some point in the future. So, Sam, thank you so much for being here talking about Bainbridge Health.
Yeah, absolutely. Thank you guys so much.
This is great. So, thank you.
You're welcome.